Welcome to the presentation of part 2 of lecture Infectious Arthritis. How we diagnose infectious arthritis. It's important to understand that neither CBC nor plain X-ray are diagnostic of septic arthritis. The characteristic clinical picture with monoarticular arthritis is in immune-compromised patient is the most important to suspect infectious arthritis. Polymorph nuclear leukocytosis is present in only 70% of cases. Regarding X-ray findings, they include periarticular soft tissue swelling, periarticular osteopenia, uniform joint space narrowing, bone erosions, fibrous or bony ankylosis. All are non-specific. Imaging include ultrasound, bone scan, and MRI are not diagnostic. The only way to diagnose septic arthritis is arthrocentesis and synovial fluid analysis and culture. This image shows arthrocentesis of knee joint medial approach. Now, what are synovial fluid findings in septic arthritis? This table shows the common bacterial etiologies of septic arthritis in both native and prosthetic joints. As you see, Staph aureus and Streptococci are the commonest organisms. Keeping in mind that the most common cause of septic arthritis in young sexually active adult is gonococcal organism that's usually associated with rash and tenosynovitis. One suspected empirical use of antibiotic is advised till the result of culture. Antibiotics are given intravenously for the first 2 weeks, then orally for another 2 weeks. Together with serial joint aspiration, this is to prevent local joint damage and systemic complications like bacteremia and sepsemia with shock. Mortality due to septic arthritis is about 8 to 15% in 3 series. Continuing treatment, there must be daily assessment of patient status, which include evaluation of temperature, strength, appetite, range of movement of the joint, and white cell count. Surgical drainage is indicated in hip infection, recurrent infection, failure of the above therapy. This table shows the recommended empiric antibiotic for adult septic arthritis based on synovial fluid gram stain results. This will be explained in details in face-to-face session. Other forms of infectious arthritis. Tuberculous arthritis, it's chronic monoarticular arthritis, could be the only manifestation of tuberculosis. Sure diagnosis is by synovial biopsy and histopathological examination. Viral arthritis, which is polyarticular, fleeting, self-limiting, associated with characteristic exanthemata, Fungal arthritis, it's chronic monoarticular arthritis with sure diagnosis by synovial biopsy and histopathological examination. Lyme disease and prosthetic joint infection, which could be one of the above types. It needs longer duration of therapy and removal of the infected prosthesis. Lyme disease. Lyme disease referred to as Lyme infection. It's multi-system bacterial illness transmitted to human by bite of infected tick carrying bacterium Borrelia burgdorferi. It's most prevalent in the northern states of United States. Lyme disease has 3 stages. Stage 1, with early localized disease, the tick bite results in skin rash known as erythema chronicum migrans. Appear 3 to 30 days after bite or insect bite, associated with fever and malaise. Stage 2, which is the early disseminated disease. Stage 3 is chronic or late Lyme disease. Monoarticular or oligoarticular non-erosive arthritis developed during stage 2 and 3, affecting large joints of lower limb. Antibodies IgG and IgM appear as early as 2 to 4 weeks after infection, detected by ELISA, followed by confirmation by Western blot test. Treatment is by antibiotic like doxycycline and ampicillin for 14 to 21 days. This is an image of erythema chronicum migraine with bull's eye appearance and the incriminated tick. Please be ready with your questions in the next face-to-face session.